talk about the different organs, what those organs are involved with. And then for the female, we're going to spend more time talking about hormones because we're going to look at two different cycles that happen in the female system. And that's the ovarian cycle, what's going on in the ovaries and how they're influenced by hormones that come from the anterior pituitary. And then we'll see that the ovaries are going to make hormones that are then going to go to the uterus and affect the uterine cycle. So we'll have those two cycles to talk about. And then we're going to talk about oogenesis, and we'll see that it's a very similar approach in terms of we'll do mitosis and then we'll do meiosis. But we'll see that there are some differences in terms of when these events actually take place. So that's what we'll do. So for the female reproductive system, here we're going to be focusing a lot on the ovaries because those would be the gonads, Those would be the gonads. The gonads for the female system. And the ovaries are going to make the gametes, which the mature gametes are the ova or ovum, singular. And that technically is what the egg is. We often use the term egg to refer to oocytes, and we'll see what the difference between an oocyte and an ovum is. And then the ovaries are going to make the female sex hormones, and the ones that we're going to talk about would be estrogen and progesterone. And we'll see that there's going to be a negative feedback system that's set up. Plus, of course, the females have to have a little bit of a complication to the whole mechanism, and that we will have mostly these hormones regulated through negative feedback mechanisms, but we'll see that with estrogen, there will be a small event of a positive feedback loop that kicks in. So we'll talk about that. Obviously, for the female system, we're going to have to talk about structures that are there to protect and support a developing embryo if there is fertilization, and then nourish that newborn infant. So we're going to have a series of accessory ducts like we did for the males. Here we're going to have the uterine tubes, or also the fallopian tubes, same thing. The uterus, then the vagina. And one thing to keep in mind for the female structures, the female structures are basically just in the middle of that abdominopelvic cavity. And so we're going to have a series of ligaments, a lot of ligaments, that are holding all of these structures in place, connecting them to one another, and then anchoring into the wall of the abdominal cavity. One of the largest ones is called the broad ligament. And what the broad ligament is, it's mesentery. And this is a term that we're going to see again when we talk about digestion. But mesentery is just a double layer of connective tissue. So we're going to have this big sheet of connective tissue that's basically double layered, and that's what a mesentery is. And so it's called the broad ligament, but I don't want you to think of it ligament like we did with the bones. Ligament is connective tissue. But when I think of a ligament, I think of almost like a rope-like structure. This is going to be flat, and it's going to envelop all of these structures, the ovaries, the uterine tubes, the uterus. So it's going to go around all of those structures. And then it's going to fuse with and anchor into the peritoneum, the connective tissue that lines the abdominal cavity. Now, so here it's continuous with the parietal peritoneum. Again, that's the part of this connective tissue that lines the abdominal cavity. And this broad ligament is going to keep things from moving side to side. And then, really important when we have a developing fetus, when that fetus starts moving around, we don't want any rotation to happen. So this is going to keep the uterus from rotating, keep everything kind of in place. And then we're going to have a lot of other ligaments on top of this. And we're not going to go through all of them, but we'll talk about some of them. So first of all, when we look at this sagittal section, we want to just define the major structures that we're looking at. And for here, it's not quite as easy to tell which is anterior versus posterior like it was for the males. So what I always look for to know that I'm on the anterior side is I look for the pubic symphysis. So this is where the two pubic bones come together and form a joint. That's going to show you that this is the anterior side. And then posterior side is where you would see the rectum and then the vertebral column coming down. Now, if we look here anteriorly, we're going to have some external genitalia here. And so you're going to have the labia major, which is a fold of skin, fold of tissue. And then you're going to have the labia minor. And then you can see all around the pubic area here, around the pubic bone area, there's a lot of fatty tissue here. And this fatty tissue is called the mons pubis. And that's basically there to help protect and cushion these structures that are housed inside. And one of the major structures that this mons pubis is going to help to protect is this little bit here of erectile tissue. Same kind of tissue that we saw in the penis, that same erectile tissue that engorges with blood. And this is the clitoris right here. Then if we come back a little bit, we have the opening to the vagina, and prior to intercourse, there's going to be a little piece of tissue here, connective tissue, that covers the opening of the vagina, and that's called the hymen. Oh, sorry, that's the bladder. Back here, sorry, back here. Gosh, okay. Back a little ways. This is the vagina, okay? A little piece of tissue right there. I should get the mirror out and recheck everything. So, make sure I'm putting things in the right spot. So the hymen here, this is often, particularly for girls that are active, the hymen very routinely gets broken early in, prepubescent kind of years. For gymnasts, and again, girls that are particularly active, that can tear. If it is intact or partially intact, first time that a female has intercourse, there's often some bleeding that takes place. And most of that bleeding is coming from that tissue just being broken and the little capillaries that are in there breaking. So that's completely normal. Then if we go past the hymen, and on the models and whatnot, you're not going to see a little band of tissue. So you should just know where it would be. But then you go into the vagina, and then you're going to hit next the uterus. The most inferior part of the uterus is the cervix. So when you go in for a pap smear, and they put that horrible big Q-tip basically up, they're scraping the surface of the cervix to look for any abnormal cells. Then we go into the uterus here, and then from the uterus we would go into the fallopian tubes. And let's see, when you look at the fallopian tubes are going to have different parts of them. And I just want to clarify, I think I told several people that the infundibulum was the part of the uterine tube that's closest to the uterus, and that's not right. I'm sorry, I misspoke. When you look at the fallopian tubes, this part over here is the infundibulum, and then coming off of the infundibulum, you have these finger-like projections that kind of look like Dr. Seuss structures or something, and these are called the fimbriae, and that is what is going to drape around the ovary. So the ovary is right here. The fimbriae come down and drape around the ovary, and then the infundibulum is the next part there of the fallopian tube. Now, on a lot of figures and on the models, it looks like there's a direct connection between the uterine tube and the ovary, but there's not. The ovaries sit like this, the fimbriae of the uterine tube drape around it, but they're not actually touching. And so that's going to be real important when ovulation occurs and an egg erupts out of that ovary. that egg or that oocyte has to get swept up into the fallopian tubes. So you're going to see the cells that line the innermost part of those fimbriae are going to be lined with cilia. And about 12 hours before ovulation happens, those cilia will start to beat, so that when that egg is released, hopefully it's going to get swept up into the fallopian tubes instead of going out into the abdominal cavity.
So are the fallopian tubes open tubes?
They're tubes,
like
yeah.
Open-ended? Or does the cilia kind of make a barrier? And then when...
It kind of has, it is an open tube, so it's open from the uterus, then you go right into the fallopian tube, and yes, it is open right there. Because it kind of drapes like this, and really there shouldn't be anything out in the abdominal cavity to go up in there. But theoretically, let's say that you had, I don't know, the intestines ruptured or something like that, something horrible happened, and there was fecal material floating around in the abdominal cavity. Theoretically, it could come up into the fallopian tubes. It could definitely do that. But the way it's kind of structured, the way it drapes over, that would be, it would be difficult for it to get up there. And because there's kind of an arch right there, again, it would be hard to kind of get up in there and then down into the uterus. But it is an open tube. Okay. Now, in front of and inferior to, so anterior and inferior to the uterus is the bladder. And coming out of the bladder would be the urethra. And you can see the urethra in females is very short compared to in males. The urethra is very long because it runs through the penis. This is one reason why females are much more prone to getting bladder infections. Because if you do have bacteria that comes from the outside or from the rectal area, from the anal area, and come up through the urethra, just a short distance to get to the bladder. Whereas for males, it would have to travel quite a long distance to get there. And also for females, when you're using the bathroom and you're wiping, really you should be very careful to make sure that any fecal material doesn't get pushed up over towards the vagina or over towards the urethra. Now, you also have a series of ligaments. And again, on the models, you're not going to be able to see all of these different ligaments. You can see some here. You can see the round ligament here. There's an ovarian ligament that we can't see on here. Here's the uterosacral ligaments. So we'll talk about some of these. Just realize that a lot of these ligaments you can't see on the models. So I'll ask you with words instead what those ligaments are. Okay. Now, this right here is a good coronal section. And so here, again, we can see the vagina, the cervix, the uterus coming off laterally from each side of the uterus. We have the fallopian tubes, and then draping over each of the ovaries. Here we can see some of the ligaments. We've got the ovarian ligament that's connecting the ovary to the lateral wall of the uterus. Here we can see part of the broad ligament, and again, this would be mesentery that's wrapping around all of these structures and then fusing with the peritoneum that would be lining this abdominal cavity. The part of the broad ligament that is right around the ovary, that is a bit thickened in that area, and that's called the mesovarium. So the mesovarium is just a thickening of the broad ligament right around the ovary. There's going to be a lot of blood vessels that run through there that are going to the ovary itself. And that's there, again, to just help protect these structures and give a routing mechanism for blood vessels and nerves that are going to these various structures. You have the suspensatory ligaments, and this is anchoring the ovary laterally to the pelvic wall. So it would come off of the ovaries laterally and then go to the pelvic wall. Those are the suspensatory ligaments. And let's see, we talked about those other ones. Okay, so since we're here at the ovaries, we're going to start talking about oogenesis. So in terms of how we make these oocytes and then ultimately the ovum, we need to go through the processes that we talked about before. So I'm just going to put them back up here. And just like before, we're going to define these different cells. So for mitosis, we're going to start with the diploid parent cell. And then you go through mitosis, and you end up with 2 daughter cells that have the same exact chromosomes. So these would be diploid also, 2N. And then for meiosis, we're going to take a diploid cell. And we're going to go through 2 rounds of division. The first division would be part of meiosis 1, and we're going to end up with 2 haploid cells here. And then each of those cells will undergo meiosis 2. And we're going to end up with 4 haploid cells. And for your lab practical, obviously you're going to have endocrine on your lab practical, you're going to have reproduction on your lab practical, and then you have a lab called gametogenesis, which is basically these cells right here. So we've already gone through spermatogenesis, we're doing oogenesis here, and then we'll talk about the follicles and what they're doing also. But for that part of your practical, obviously I don't have models to show that, so I'll just ask you with words. So I might say something like, for spermatogenesis, which cell begins meiosis 1? And that would be your primary spermatocyte. I might say, is that cell diploid or haploid? And that would be a diploid cell. I might say, what cell do you get at the end of meiosis 2 in spermatogenesis? And those would be spermatids. Are they diploid or haploid? So that's how I'll ask you questions about the gametogenesis part of things. Now remember, when we're doing these parts of mitosis and meiosis, there are different phases of these rounds of cell division. And those phases are prophase, metaphase, anaphase, and then telophase. And again, this has to do with what are the chromosomes doing during that round of division. And for meiosis, we'll have prophase 1, metaphase 1, anaphase 1, telophase 1, and then prophase 2, metaphase 2, anaphase 2, and telophase 2. Now for males started this whole process at puberty, and then it just continued pretty much continuously throughout their whole life. Females, it's going to be quite a bit different. When we start these different processes, and then we're going to see that they'll be halted for periods of time, and then they'll start back up at other times. And the other thing that we're going to see is different between males and females is when this happens, the fact that things get halted, it's not continuous. And we're going to see that when the cells divide, they're not going to be equal in size when we do these different divisions. For males, when you did mitosis, the two daughter cells, size-wise, were the same as the parent cell. When we were up here and we had the primary spermatocyte, then giving rise to secondary spermatocytes, the cells were all the same size. The secondary spermatocytes gave rise to spermatids. Those cells were all the same size. That's not going to be true for the female system. We're going to see that when we go through meiosis, when we're done with meiosis 1, these cells are not going to be equal size. One is going to be much larger than the other. And then when that cell goes through meiosis 2, we're going to see that we end up with one really large cell that will can ultimately become the ovum. And all the other cells are going to be very small. They're going to be called polar bodies, and they basically are going to die off. And think about why that would be the case. Remember that with sperm cells, once we got the spermatids, then the next step was spermiogenesis. We got rid of lots of the organelles. Most of the organelles, most of the cytoplasm. We made those cells really small and very streamlined. So what that means then is the ovum has to compensate for that. The ovum has to be that much larger so that when the egg and the ovum come together, you get a normal-sized zygote, not a cell that's too small. So the ovum's going to have to be much bigger than a normal cell that you would get down here. It's going to have a lot more cytoplasm. It's going to have a lot more organelles. So not only is the ovum bringing the chromosomes like the sperm does, but it has to bring most of the organelles, most of the cytoplasm, a lot of nutrients, so that when we get that zygote, it's big enough then to start dividing, undergoing mitosis, and eventually leading to a multicellular organism. Right? So we're going to see that happening here. Now, this process is also going to be mediated, like it was in the males, under the influence of the gonadotropins that are coming from the anterior pituitary. So FSH and LH are coming from the anterior pituitary, and they are going to trigger this process. Now, for males, this all started at puberty. For females, this is going to actually begin in utero. So in utero, around the 3rd to the 7 months, fetal development is when we're going to start to see this process happening. So for females, we're going to start out with an oocyte stem cell, just like we did in males, and that's going to be called the Oogonias. And again, this is going to happen in utero. So in utero, we're going to have a population of Oogonias, and those Oogonias are going to undergo mitosis. And they're going to produce 2 diploid daughter cells that are called primary oocytes. And all of the Oogonias are going to go through mitosis, and they're going to produce primary oocytes, and all of those primary oocytes are going to start meiosis. In males, half of these cells went into meiosis, and the other half of these cells stayed up in the seminiferous tubules and went through mitosis again, so that we always had stem cells there for the males. Females were not going to do that. All of these cells are going to go through mitosis. All of these primary oocytes are going to start meiosis. And again, this is in utero still, but they're not going to get very far. They're only going to just start meiosis, and they're going to get halted at prophase 1. So in utero, our oogonias are going to go through mitosis and produce diploid primary oocytes. All of those primary oocytes are going to start meiosis, but they're only going to get through the very first part of meiosis, and then they're going to get halted at prophase 1. And then that's what we're born with. Females are born with no oogonias. They're born with only primary oocytes in their ovaries, and those primary oocytes are halted at prophase 1. And we'll talk about the follicles. These oocytes are actually encased in cells that are called follicles, and we'll talk about those in a second. So this is what we're born with. And then nothing's going to happen to those cells until we hit puberty. So all during the rest of the fetal development, nothing's going to happen to these cells. All through childhood, they're just sitting there. A lot of them will die off along the way, but basically they're just sitting there waiting. Now, when puberty kicks in, we're going to have our first ovarian cycle. And then every month until menopause occurs, we're going to have an ovarian cycle. And ovarian cycles are going to be triggered by having LH and FSH levels starting to rise. So LH levels and FSH levels starting to rise triggers an ovarian cycle. And that's going to happen every month, starting at puberty and going to menopause, unless something weird's going on with the body. Then it can halt. But we're going to assume everything's normal. Now, what's going to happen when FSH and LH levels start to rise? That's going to trigger, sorry, I think that's my phone. Forgot to turn it off. LH and FH levels are going to start to rise, and what's going to happen is some of these primary oocytes, not all of them, but some of them are going to continue going through this process, and some are just going to sit there and do nothing. And then the next month, those primary oocytes that started this process, they're going to keep continuing this process. And then some new primary oocytes are going to start this process. And the other ones are just going to sit there. And then the third cycle, the primary oocytes that started 2 cycles ago, they're going to keep going through this process. And the ones that started the cycle before, they're going to continue going through the process. And then some new ones are going to start the process. And that's just going to keep happening every month. You're going to have new ones jumping in and starting this process, and the ones from the previous cycle are going to continue going through this process. So it potentially could take a whole year, 12 cycles, for a primary oocyte to start or continue this process and actually get to a point where we have a cell that's ready to be ovulated. Okay, so it takes a while. So that first year, when a female first starts her cycle, usually it's almost a year before she could actually get pregnant, before she has a cell that's ready to be ovulated. Now, I wouldn't bank on that, right? But, you know, at least it should take several cycles before she has a cell that's ready to be ovulated and that can get fertilized. Okay? Don't tell your teenagers that, but that's probably a good rule of thumb. Now, what's going to happen is, obviously, not every cell that starts this is going to be able to get ovulated. So many cells, most of the cells are going to die off because they're going to reach maturity at not the right time during the cycle to get ovulated. So they're just going to die off. And it happens in such a way that once you're well into the cycle, let's say a year into having these cycles, then every month at just the right period of time in the cycle on day 14, you're going to have one cell that's just the perfect maturity that's going to get ovulated and can be fertilized. And all the other cells will just die off, or they'll continue maturing in the next cycle. And you're going to have a large population that are just sitting there for years and years and years not doing anything. So when you hit menopause, you'll still have some primary oocytes halted at prophase 1 that never went through this cycle. They just are going to end up dying off because you'll stop having cycles. Okay? Now, what's going to happen is, so again, every month, once you hit puberty, LH and FH levels are going to start to rise. And that's going to cause some of your primary oocytes that were halted at prophase 2, they're going to continue going through meiosis 1. When they finish meiosis 1, then they're called secondary oocytes. And what we're going to get after meiosis 1, we're going to get one secondary oocyte that's a pretty good size, pretty big, and then we're going to get another one that's really small. And this really small one is called a polar body. And most of the time, that polar body is just going to die off. It will just get broken down and recycled. Then that secondary oocyte will start going through meiosis 2. But again, it's not going to get real far. It's going to get to metaphase 2 and then be halted. Now again, it's going to take several cycles to go from a primary oocyte that was halted at prophase 1 to get to a secondary oocyte, and then the secondary oocyte get halted at metaphase 2. That's going to take several cycles for that cell to get to that particular point. But you're not going to ever go further than a secondary oocyte halted at metaphase 2. That's as far as it's going to go. In order to finish meiosis 2, fertilization has to occur. Okay? So if fertilization happens, if this cell gets ovulated, so it's going to be a secondary oocyte halted at metaphase 2 that gets ovulated. If that ovulated oocyte gets fertilized, then it will complete meiosis 2. And you'll end up with a large haploid ovum plus a really small polar body. And that polar body will just die off. And inside of that ovum will be our low sperm cell. So it's a misconception that when fertilization occurs, that's the moment of conception. It is not. When fertilization occurs, it's the sperm fertilizing this ovulated secondary oocyte that's halted at metaphase 2. When that happens, the sperm cell fertilizing that egg triggers that oocyte to finish meiosis 2, becoming an ovum. And once that occurs, it takes about 12 hours or so, then the chromosomes merge together. That's the moment of conception. That's when you get a zygote. that's when you get the first diploid cell of the new organism. So when we look at this diagram here, these guys, if for some reason that polar body didn't die off, it could undergo meiosis too, but you're just going to end up with two little tiny polar bodies, and they'll just eventually die off also. So usually this guy dies off soon, and it doesn't ever get the chance to undergo meiosis two. But if it didn't die off right away, it could undergo meiosis two, ending up with two tiny little polar bodies, and eventually they would just die off. If the secondary oocyte halted at metaphase 2, if it's ovulated and it gets fertilized, then you're going to end up with a large haploid ovum. Again, the sperm cell would be inside of there. And then you're going to end up with this little polar body that's going to die off. And again, the reason why these polar bodies don't have any functional significance, the only reason you have polar bodies is because all of the majority of the organelles in the cytoplasm are going to making this large ovum to compensate for the fact that the sperm cell is so small. So that when we get the zygote from these two cells mixing, it's a normal size. Now, just,
If the secondary oocyte doesn't get fertilized, then it just never finishes.
right,
meiosis.
yeah, it'll just die off in the fallopian tubes. And if it doesn't get ovulated, it will just die off in the ovary. Yeah.
When does that happen?
When does what happen?
When does the die-off happen? That same cycle? Or that same...
Oh, it would start dying off pretty quickly, yeah. It would die off pretty quickly. Okay. Now, generally, like I said, there's going to be one secondary oocyte that's halted at metaphase 2. That's just the perfect size, everything's right on day 14, and that's the one that gets ovulated. And whether it comes from the right ovary or the left ovary, that's completely random. There's no rhyme or reason as to which one. This is happening in both ovaries, and so generally there's going to be one in one of those ovaries that is just right at that particular time, and it gets ovulated. Sometimes you'll get more than one secondary oocyte halted at metaphase 2 that gets ovulated. And that's how you can end up with twins, fraternal twins. Now, identical twins is when you have that zygote starts to divide and will then split, and you can end up with twins after you have implantation in the uterus. That's identical twins. But having multiple oocytes being released from the ovaries is how you can get fraternal twins. And when you take fertility meds, what it basically does is it increases the odds that you're going to have secondary oocytes halted at metaphase 2 that are just the right size on that day to get ovulated. And so that's how you can end up with a brood, right? You end up with 8. Yeah. That's crazy. But you have to have fertilization to finish meiosis 2. There's no other way to finish meiosis 2 unless fertilization happens. June.
So, what about fertilization? Do they really fertilize?
Say it one more time.
In vitro?
Yeah, they will take out the eggs, fertilize them. They'll basically take out the oocyte, fertilize them. That then triggers that oocyte to finish this round of meiosis, and then the chromosomes mix, and then they implant that.
How do they do that, and how do they harvest that?
It's actually pretty easy. The follicles that house these oocytes sit on the surface of the ovaries, and so it's actually pretty easy to just kind of pluck them out almost. And then with the microscope, you can kind of tell what stage they're at. So then you pick one that's, right about this stage, and then you can look at the chromosomes and see, are they all lining up, telling you that they're in metaphase, and those would be the ones that you would then fertilize. Yeah. And then you just stick them back in an incubator and let them, kind of finish this process. And then
How long are they incubated?
Oh, this would probably take not very long, hours, a few hours. I don't know what they do in a clinical setting, but a few hours, and they should be ready to go.
When does identical twins, when do they?
So that's going to happen early after implantation, usually.
Like how early?
Within the first, couple, so it takes about 7 days to get implanted after fertilization. So within the first, first 2 weeks or so. Something like that. I don't know exactly, but I'm just kind of guessing. It's pretty early. Something like that. Okay. Now, we're going to build on this. So if you have questions, make sure that you're asking. So what we want to do now is we've talked about why you have polar bodies, why these cells are different sizes. We've defined the names, and we've said when these different events happen. And so now we want to say, what's up with these follicles? So the follicles are just rings of cells, and the oocytes are going to be in the follicles. And then that whole thing, the follicle plus the oocyte, is in the ovary. And you're going to find the follicles with the oocytes in them generally on the surface of the ovary. Certainly the more mature they are, the closer to the ovary edge that they are, so that when the follicle ruptures, they can be released from the ovary. Okay. So what you're going to start with is when you're born, you're going to, well actually the first follicle that you have is called a primordial follicle. And that basically is just a single ring of cells. That's the primordial follicle. Very simple in structure. And then again, you would have the primary oocyte inside of that primordial follicle. So when we're born with primary oocytes halted at prophase 1, and they're in primordial follicles. Then, when puberty hits and we get FSH and LH levels rising, FSH is in particular going to target the follicle stimulating hormone. So that primordial follicle is going to be stimulated by FSH. And that's going to cause the primordial follicle to then become a primary follicle. And then primary follicles will turn into secondary or mature into secondary follicles. Secondary follicles will then become tertiary follicles. Tertiary follicles are also called Grothian follicles or mature follicles. And those are going to be the ones that rupture on day 14 under the influence of LH, luteinizing hormone. So the follicles go primordial follicle, primary follicle, secondary follicle, tertiary follicle. And then it's the tertiary or mature or Grothian follicle that can rupture on day 14 under the influence of LH, luteinizing hormone. Now, inside of those follicles, again, these cells, these oocytes, are undergoing their divisions. And I'm not going to ask you when your primary oocyte is in anaphase, what follicle is associated with it. I'm not going to ask you to line those up because it's not a completely linear process between the two. What you should know is when you're born with primary oocytes halted at prophase 1, and they are in primordial follicles. When you have ovulation of a secondary oocyte halted at metaphase 2, it is being ovulated out of a mature or Graafian follicle. And then every oocyte in between is going to either be in a primary follicle or a secondary follicle leading up to that tertiary follicle. And again, I'm not going to ask you to line those up. Now, the follicles are important because not only are they housing these oocytes, but as the follicle starts to mature, it gets thicker. The cells that make up that follicle, they're going to get more numerous, and they're going to start to become very specific cell types. So when you get this increase in FSH at the beginning of the cycle, and the follicles start to mature, once you go from a primordial to a primary follicle, in these primary follicles, you'll start to produce what are called fecal cells and granulosal cells. And those cells start to secrete estrogen. So primordial follicles don't secrete estrogen. But once you get a primary, a secondary, or a tertiary follicle, they are secreting estrogen. So, over here. Primordial follicles are activated at puberty. An activated primordial follicle will either mature into a primary, then a secondary, then a tertiary follicle, and then release a secondary oocyte halted at metaphase 2. Follicle development can take up to a year. We said that for an oocyte, a primary oocyte halted at prophase 1, to get to a secondary oocyte halted at metaphase 2, which means you're going from a primordial follicle to a mature tertiary or Graafian follicle. That process can take up to a year.
You need to ask us on the test to write this out in words. Would you care if we wrote it as Graafian or secondary?
No, you can use any of those terms. Any of those terms are fine. Okay. So, they can either, those follicles will either mature or they will break down. They will break down and get recycled. So obviously, like we said, not every single follicle is going to rupture and release an oocyte. So most of these follicles, most of these oocytes are just going to break down. They're just going to get broken down and recycled because they're not going to reach that perfect state on day 14 of the cycle. They're either going to be too young come day 14 of the cycle, and then that means the next month they'll keep maturing, or come day 14 of the cycle, they're going to be too mature and they'll just die off. So if they're too immature, they'll keep maturing in the next cycle, and maybe they'll hit that right size, that right maturity on day 14, or not. They're either going to undershoot it or overshoot it. And if they overshoot it, they're just going to die off. Now, when we look at the ovarian cycle, we want to say, what are the different phases of the ovarian cycle? What's happening in these phases, and what hormones are influencing these different phases? And then what hormones are being released from the ovary. So I'm going to erase this stuff so we can put up the cycle. Now again, we're going to look at the ovarian cycle, and then we're also going to look at the uterine cycle as well. Right now, we're just going to look at the ovarian cycle. But I want you to keep in mind that what happens in the ovarian cycle is going to influence what happens to the uterus. So we're going to come back and line these two cycles up. So first of all, in the ovary, And we're going to take a typical cycle, and this will vary from person to person. So we're going to take the ovarian cycle, and we're going to have a 28-day cycle. So day 14 of this cycle is going to be when ovulation occurs. So what's going to happen, what's going to trigger this cycle every month is hormones are going to come from the anterior pituitary, and at the beginning of this cycle, you're going to see FSH and LH levels start to rise. They don't rise a lot, but they rise just enough that it's going to trigger this cycle. And it's really FSH rising that triggers the start of this cycle. So having these levels starting to increase, particularly of FSH, is going to trigger follicles to start developing. So again, you're going to have every month, you're going to have many primordial follicles becoming primary follicles. And every month you're going to, assuming, let's say we've been in this cycle for at least a year, okay? So we have things at different stages of development. So every month we're going to have many primordial follicles stepping up to the plate and maturing and becoming primary follicles. Then we're going to have a few primary follicles from the month before or 2 months before, maturing into secondary follicles. And then we're going to have generally one secondary follicle maturing into a tertiary or a mature or a Graafian follicle in that given month. And again, inside of these follicles, the oocytes are going through their rounds of division. Now, that's going to happen here under the influence of FSH. So when FSH levels rise, many primordials are starting on their way to becoming primaries. A few of the primaries are on their way to becoming secondaries, and generally one secondary is on its way to becoming a mature or Graafian follicle. Now, once you get a primary follicle being made, then again they become bigger, more cells. The cells of the follicle start dividing, and those cells can become fecal and granulosal cells, and they start secreting estrogen. So a few days, usually it's about 4 days or so, from the beginning of this cycle, you're going to see estrogen levels starting to rise. And estrogen levels are going to start to rise because as these follicles are maturing, they start to secrete estrogen. So that increase in estrogen is coming from the follicles, from the maturing follicles.
Primary ones in particular?
Primary, secondaries, tertiaries are all going to be secreting estrogen. Once you get to a primary follicle, then anything after that can be secreting estrogen. Now, this estrogen is going to be important because it's going to target many cells of the body, but in particular, we're going to be concerned with how it affects the uterus, okay? And we'll talk about that later. Now, this period of time from 0 to day 14 is called the pre-ovulatory phase. It's also referred to as the follicular phase of the ovarian cycle. And that's because that's when your follicles are maturing. Follicles are maturing and they start to secrete estrogen. Now, on day 14, what's going to happen is on day 14, you're going to get a surge of LH coming from the anterior pituitary. And we'll talk in a minute about why there's a surge of LH. You're going to get a surge of LH. You also see a spike in FSH, but it's really that surge in LH that triggers ovulation. So whichever follicle is at the perfect size maturity on day 14, when we get that surge, that's going to be the follicle that ruptures. And out of that follicle is going to come a secondary oocyte, halted at metaphase 2. So from day 14 to day 28, this is referred to as the post-ovulatory phase. It's also called the luteal phase of the ovarian cycle. So what's going to happen here? That secondary oocyte halted at metaphase 2 ovulates on day 14 because that surge in LH triggers ovulation. It makes that follicle rupture. So out comes the oocyte, it goes into the fallopian tubes. And that oocyte can stay in the fallopian tubes for about 24 hours. Sometimes you see 48, but about 24 hours. So what that means is you could have had sex the day before, and the sperm cell are up there in the fallopian tubes. So the sperm can get there before ovulation, and then ovulation happens and you can have fertilization. Or you can ovulate and then have sex about a day later, and the sperm come, and you can still get pregnant. So there's about a 3-day window that you can get pregnant. Okay? So you can have sex before ovulation, you can have sex after ovulation and still get pregnant. Now, if fertilization happens, actually, let me back up just for a second. That Graafian follicle that ruptures. The follicle is still part of the ovary. It's just on the surface of the ovary. But all those cells of the follicle are still there on the ovary. It's just the oocyte that leaves. Those remnant cells of the follicle, they will become a new structure called the corpus luteum. So let's put that up here. So the remnant follicular cells become a endocrine secreting structure called the corpus luteum. And that's why this is called the luteal phase, because this is when you form the corpus luteum. If fertilization happens, and there's going to be hormones that are released that keep the corpus luteum until placenta forms. Which will take about 3 months or so. If there's no fertilization, then the corpus luteum is going to die off in about 12 to 14 days. So if there's fertilization, the corpus luteum, which is just remnants of that follicle that ruptured, if there's fertilization, that corpus luteum is going to stay there in the ovary, and it's going to be secreting hormones. And it'll do that till the placenta forms, and then the placenta will take over and secrete hormones. that are going to maintain that pregnancy. If there's no fertilization that happens, then the oocyte will just die off. It won't finish meiosis 2. It'll just die off there in the fallopian tubes or in the uterus, wherever it ends up dying off. The corpus luteum will die off around 12 to 14 days later. Now, the corpus luteum is important because it is a hormone-secreting structure. It is an endocrine structure. And what it produces is progesterone. A little bit of estrogen, but a whole lot of progesterone. So you're going to see, about a day or two after ovulation, when that corpus luteum has formed, you're going to see progesterone levels starting to rise. Because progesterone is coming from that corpus luteum. Again, it'll also secrete estrogen, but it's really the progesterone that's important here. And again, this is coming from corpus luteum. So if there's no fertilization that happens, the corpus luteum's going to die off right around day 28 of this cycle. And that means progesterone levels are going to plummet. And that also means estrogen levels will drop too. Now, if there's no fertilization and progesterone levels drop and estrogen levels drop, then what does that say about what's going to be happening to the hypothalamus? Is it going to be less or more inhibited if these hormone levels start to drop? Think about testosterone. When testosterone levels are high, is the hypothalamus more or less inhibited? It's more inhibited, right? So if testosterone levels are high, then the hypothalamus is going to be more inhibited, and that makes the hypothalamus make less GnRH, which makes the anterior pituitary make less FSH and LH, which causes the gonads, the testes, to make less testosterone, bring it back down into normal range. Okay? Same kind of things happening here, right? So beginning of the cycle, FSH and LH levels are high, then that's going to cause estrogen levels to start to rise. Corpus luteum forms, progesterone levels are going to start to rise. If there's no okay, so let's not even go there yet. As these hormones start to rise, estrogen and progesterone levels start to rise. That's going to go up to the hypothalamus and tell the hypothalamus to make more or less GnRH. Less. Make a little bit, it's not a lot, but a little bit less GnRH, which means FSH and LH levels start to drop a little bit. And that's good because we don't want to start making more follicles mature at this point. We want follicles to mature right here. Okay. So these hormones being high during the cycle keeps FSH and LH levels a little bit on the lower side. Then, if there's no fertilization and the corpus luteum dies off right here, progesterone levels drop, estrogen levels start to drop. Is the hypothalamus more or less inhibited? Less inhibited because there's less estrogen, less progesterone. And if there's less, because the corpus luteum has died, progesterone levels drop, estrogen levels drop, then that means the hypothalamus is less inhibited, so it starts to make more GnRH, which means the anterior pituitary starts to make more FSH and LH, and that starts a new ovarian cycle, right? So corpus luteum dies off here, progesterone levels plummet, estrogen levels drop as well. That then will allow FSH and LH levels to start to rise, and that triggers a brand new ovarian cycle. And we do the whole thing all over again.
What if fertilization happens and progesterone starts to decrease, or
You'll probably have a miscarriage.
right? Is that a corpus luteum malfunction. I don't know how to word it, but is that because, yeah,
If
I mean,
progesterone levels drop, it could be a lot of reasons why
Okay.
progesterone levels were dropping. If they do drop, chances are really high you're going to lose that pregnancy. For pregnancy, you need progesterone levels to stay high. And one way progesterone levels stay high is because the corpus luteum is going to stick around until the placenta forms, and then the placenta will make progesterone. So for a pregnancy, progesterone levels stay high. If they start to drop, that's going to probably cause a miscarriage, but lots of things can cause progesterone levels. It wouldn't have to just be corpus luteum. It could be other things.
LH maybe, or?
LH and FSH shouldn't be factors at that point, right? Because if we have fertilization and we keep the corpus luteum around, progesterone levels are going to stay high, which then means that the hypothalamus is going to be more inhibited. So FSH and LH levels stay low, and so then we never start a new cycle. Because if you're pregnant, you don't want to make more follicles start to develop. So you could have a problem with the anterior pituitary, and that's affecting it, but it could be so many different problems that's going on. Okay? Questions on this? So key thing, the ovarian cycle is influenced by hormones from the anterior pituitary. Ovarian cycle starts when FSH levels start to rise. Ovulation happens when you get a surge in LH. The ovaries then, because of this cycle, start to make estrogen and progesterone. And these two hormones are going to affect many cells of the body. But one thing that we're going to be very concerned with, these two hormones, estrogen and progesterone, are going to dictate what happens in the uterus. And for a pregnancy to occur, we've got to have follicles developing, ovulation, and then fertilization. But we also have to have the uterus prepared to have that pregnancy. And the uterus is going to be prepared because of estrogen and progesterone. We'll talk about those next. So the uterus is influenced by estrogen and progesterone. Estrogen's coming mainly from the maturing follicles. Progesterone's coming mainly from the corpus luteum. FSH and LH from the anterior pituitary trigger the ovarian cycle, trigger ovulation to happen. Okay, now let me see if there's anything else I want to say about this. Okay, so we need to say, why is there a surge in LH here? Why do you get this surge? Now, I said that for the most part, estrogen and progesterone are going to work through negative feedback mechanisms. I'm going to skip to many slides and then we'll come back to everything I'm skipping through here. These are two graphs that we're going to come back and talk about. So what this graph is looking at here, these are looking at your anterior pituitary hormones. Down here, these are looking at estrogen and progesterone that come from the ovaries. Now, here at the beginning of the cycle, you can see that FSH and LH levels rise just a little bit, not a lot. This would be at the end of the cycle, over here, towards the end of the cycle. And again, towards the end of the cycle, not at the very end, but towards the end, estrogen and progesterone levels are a bit on the higher side. They're inhibiting the hypothalamus. That keeps FSH and LH levels a little bit on the low end. Then, when the corpus luteum dies off, progesterone levels, estrogen levels are going to drop. That's going to allow FSH and LH levels to rise just a little bit, enough to trigger a new cycle. So FSH and LH levels are here. You can see as the follicles start to mature, estrogen levels start to rise. Once the corpus luteum forms, day 14, corpus luteum forms, progesterone levels start to rise. Now, estrogen and progesterone are going to go back up to the hypothalamus and inhibit the hypothalamus. And that's going to keep FSH and LH levels from getting any higher because we don't want to trigger new follicles later in this cycle. But estrogen's going to do a weird thing. It's going to be, estrogen levels rise, it's going to be inhibitory to the hypothalamus until when estrogen reaches a certain value, a certain threshold value, and estrogen levels are going to keep rising, 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 rising as more and more follicles mature. Estrogen levels are going to rise, 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 rise. For most of that early part, it's going to inhibit the hypothalamus and keep FSH and LH levels low. Not super low, but low. Once estrogen reaches a certain value, this kind of threshold value, then it's going to actually excite the hypothalamus and the anterior pituitary and cause the anterior pituitary to release a surge of FSH and LH, and that's what triggers ovulation. So estrogen is inhibitory to the hypothalamus and the anterior pituitary to a point. Once estrogen reaches this threshold value, and you can see estrogen values are rising, rising, rising from those maturing follicles. Once it reaches a certain threshold value, then it's going to cause the anterior pituitary to release FSH and LH in a gush. That's going to trigger ovulation. Then, once that ovulation happens, estrogen levels are going to start to drop a little bit because the follicles aren't maturing anymore. They matured during this part. Now the corpus luteum forms. Progesterone levels really skyrocket, and then that goes to the hypothalamus and causes the hypothalamus to be inhibited. That brings FSH and LH levels down, and that's a good thing in case we are going to have fertilization in a pregnancy. We don't want to have a new ovarian cycle. We want FSH and LH levels to be low. When the corpus luteum dies off, estrogen and progesterone levels plummet, and we see FSH and LH levels starting to rise, triggers a brand new ovarian cycle. So, make sure that you're walking through this and all of that makes sense. It's a little bit confusing at first, but once you walk through it a few times, it should start to fall into place. Remember, it's all about negative feedback mechanisms. FSH and LH are triggering the ovaries. Estrogen, progesterone come either from the developing follicles, from the corpus luteum. They're going to influence the uterus. Talk about that soon. Questions on this so far? Okay. So, over here, when you look at the ovary, you can see, particularly if you're looking at an adult female, you're going to see follicles at different stages of development. So you'll see lots of primordial follicles. You'll see some primary follicles. You'll see some secondary follicles. And the follicles are going to tend to always be on the surface of the ovary. And you can look at ovaries of a young female and an older female and be able to tell which is which. Because whenever you have a mature follicle rupturing and releasing that oocyte, it's going to leave a little pock mark on the surface of the ovary. Kind of like the moon has the little pock marks on it from the meteors, right? Hitting it. Whatever, rocks hitting it. Space stuff hitting it.
Space junk.
When you look at a younger female's ovary, it's going to be much smoother because she hasn't had as many ovulations. Now, what we looked at the other day, we looked at the ovary and we looked at a structure like this. And what this is looking at is, in here would be the oocyte, this round area here in the middle, that would be the oocyte. That part in the middle would be the nucleus of the oocyte. And then all around here would be the follicle. And this is a pretty developed follicle here. So this is probably going to be, a secondary, getting close to a tertiary follicle. Obviously, the younger they are, the smaller the follicles are. If it's a primordial, it's just going to be a single layer of simple squamous epithelia with the oocyte in the middle. As they get bigger, then you've got granulosal cells, thecal cells that are secreting that estrogen coming from there. Again, the corpus luteum will stay there in the ovary. No fertilization. It will just die off after 14 days or so. Okay. Move over to the fallopian tubes. So the fallopian tubes are just tubes that are there to receive that ovulated oocyte and provide a place for fertilization to happen. So the sperm have to make it through the vagina, through the uterus, get into the fallopian tubes, and then that's when fertilization will occur, is in those fallopian tubes. When you look at the fallopian tubes, they have different parts to them. And just like the tubes in the male reproductive system, they're going to be lined with some kind of epithelia, and then most of the tube is just going to be layers of smooth muscle. So that tube can contract, and that can help to move the oocyte through it, and that can help to move the sperm through it as well. And that would be under sympathetic stimulation, just like in the male system. There's different parts of the uterine tube. The infundibulum, this is going to be the part that's closer to the ovary. The fimbriae are going to come off of the infundibulum and drape over the ovary. And again, the fimbriae are the finger-like projections. They're going to be lined with cilia. And right about 12 hours before ovulation, those cilia are going to start to beat. And when that oocyte is released, the cilia beating is going to help sweep that oocyte up into the infundibulum of the fallopian tube and then propel it towards the uterus. Remember, there's no physical connection there. It just drapes over. The ampulla is the middle portion of the fallopian tube. Here you're going to have lots of layers of smooth muscle cells that are going to contract under sympathetic stimulation. And remember, in the semen, there are chemicals that cause smooth muscle to contract. What's that chemical called? Prostaglandins. So in the semen, there's prostaglandins that's causing this smooth muscle to contract. So even if the female having sex, if she doesn't have an orgasm, doesn't have that sympathetic stimulation to cause the smooth muscle to contract, you can still get the oocyte moving and the sperm moving aside from the flagella because of those prostaglandins in the semen. The isthmus is the short section that connects the fallopian tube to the uterus. So those are just different parts of the fallopian tube. Now, traveling through the fallopian tube, again, we talked about the fact that the cilia will beat. It takes about 3 to 4 days for the oocyte to travel from the infundibulum to the uterine cavity. And I've seen this even be longer, pushing 7 days. But about, I would say more like 4 days for it to travel. If fertilization is going to happen, generally that oocyte has to meet the sperm within an hour of it being ovulated. But again, the sperm can hang out in the fallopian tubes before the oocyte is ovulated. So there's going to be a window of time there. And the tubes are releasing nutrients. So they're secreting material. They're secreting lipids. They're secreting glycogen, and the sperm cell can use that glycogen, even though it prefers fructose. It can use that glycogen, get glucose from it, use that to make ATP. It can use the lipids also to make ATP. Those nutrients that the fallopian tube are secreting can help the sperm stick around for a couple days but it also is going to be important for the pre-embryo. Because if fertilization's happening in the fallopian tubes, that zygote is going to actually start undergoing mitosis there in the fallopian tubes. And as it's undergoing rounds of mitosis, it's going to be moving down towards the uterus. And eventually it will implant in the uterus, but it's got to survive the fallopian tubes. And one way it's going to survive is by getting nutrients from the fallopian tubes. Okay, go to the uterus. Uterus is a hollow organ. So that means the innermost part's going to be lined with epithelia. It's going to have a very thick layer of muscle in there, and that's going to be important for supporting this developing embryo and fetus, and then it's going to be important for labor. That smooth muscle has to contract to get that fetus out. Now, again, you're going to have a variety of ligaments that are helping to support the uterus. So you're going to have the uterosacral ligaments. These are ligaments, connective tissue that run from the posterior, or I guess lateral sides of the uterus back to the sacrum. This is going to keep the uterus from moving inferiorly and anteriorly. And then you have the round ligaments that are coming off of the lateral aspect of the uterus and then embedding into the connective tissue associated with the genitalia, and this is going to keep posterior movement from happening. Now, what you can see sometimes is, particularly in women that have had a lot of pregnancies, remember, connective tissue, as it gets stretched, it becomes weaker. Those collagen fibers never quite repair themselves as well as they were originally. We talked about this with joints. And this is going to be true also for these ligaments. As they get stretched, they're going to become weaker. They're not going to be as strong. And so if you have a female that's had a lot of pregnancies, when she gets older, you can have what's called a prolapsed uterus. The uterus can prolapse or drop so much that you can actually see the cervix at the most external part of the vagina. So if you're an older female and you see something there in the vagina that you know you didn't put in there, might be your uterus. So be careful about that. What they basically will do is they'll go in and they'll cut these ligaments and they'll rehoist the uterus back up. So they'll cut them, make them shorter so they have more tension to them, and then suture them back together. It's not a pretty thing, but it's not all that uncommon either.
Is it painful?
It can be very painful, yeah. Because ligaments usually have a lot of receptors associated with them, pain receptors. Okay, so when you look at the uterus, again, the cervix is the most inferior part that projects down into the vagina like it should. You're going to have a series of cervical glands that are secreting mucus. And the primary job of that mucus is to help keep the sperm from getting past the cervix into the uterus and then into the fallopian tubes. Right around ovulation, about a day or so on either side of ovulation, a lot of women can tell that they're ovulating because the consistency of that mucus changes, and it'll get thinner to allow the sperm to be able to pass through easier. Now remember, the sperm also, in the semen, they're going to have a variety of enzymes that can break down that mucus as well. When you look at the uterine wall, the outermost part, which is just connective tissue, fancy word for it would be the visceral peritoneum. The parietal peritoneum is the part of that connective tissue that lines the abdominal wall. The part that lines the organs would be the visceral peritoneum. It's also called the perimetrium or the serosa, which is the connective tissue on the outer part of the uterus. The majority of the uterus is smooth muscle. 90% of it is the myometrium. The innermost part is the endometrium. Endometrium is going to be epithelia and then connective tissue. And it's this endometrium that's going to change over the course of a month due to estrogen and progesterone coming from the ovaries. And it's going to be all but the deepest part of the endometrium that sloughs off every month in the uterine cycle or the menstrual cycle. Uterine cycle, menstrual cycle, same thing. So the menstrual cycle is solely due to changes in the endometrium. And the endometrium changes because of the hormones that are coming from the ovaries. And the ovary changes due to hormones coming from the anterior pituitary. So we definitely want to know what these different phases of the cycles are, what triggers those different phases, what hormones are released, if any, and then what those hormones are going to do. And we'll put all that together here. Okay, now, so we're going to go into the uterine cycle. Now, the uterine cycle, we're going to line up here with the ovarian cycle. I'm just going to move this up a bit. So we said up here we've got increased estrogen. It's coming from the follicles. And then up here we've got increased progesterone coming from the corpus luteum. And then you'll also see a little bit of estrogen coming from the corpus luteum as well. Okay, so the uterine cycle. We're going to take our same 28-day cycle. And again, this is what's happening to the endometrium. So when you look at the uterine cycle, here we're going to have 3 phases. Ovarian cycle, we had 2, the follicular phase, the luteal phase. Uterine cycle, we're going to have 3 phases. From about day 0 to about day 5. And again, this will vary from person to person. But the first part of the uterine cycle is called the menses. The second phase, it goes out to about day 14. This is called the proliferative phase. And then from day 14 till the end of the cycle, this is the secretory phase. Now, what the uterus is doing is the endometrium is going to change to get ready for a possible implantation. So if there's a fertilization that happens up here through the ovarian cycle, we want to make sure that the uterus, the endometrium, is nice and thick so that we can have implantation. The endometrium needs to be thick and secreting a lot of nutrients to support that embryo. So the uterus is getting ready for implantation. And if there's not a fertilization, then we're going to slough off all that material, kind of clean it out, clean house, and then get it repaired, build it back up again. So what's going to happen here is, if we look at the end of an ovarian cycle, if there is no fertilization, then the corpus luteum dies off. And when the corpus luteum dies off, progesterone levels and estrogen, but mostly progesterone, plummet. And when progesterone levels plummet, that triggers the endometrium to slough off. And so a drop in progesterone levels triggers the first part of the uterine cycle. So the menses, this phase is the endometrium sloughs off. And again, it does that because progesterone levels drop, and progesterone levels drop because the corpus luteum died off. Then, around day 5, estrogen levels are starting to rise. And so an increase in estrogen triggers the proliferative phase. Now again, estrogen levels are starting to get nice and high right around day 5, because on day 0 up here in the ovarian cycle, the follicles start to mature, and as they mature, they start to secrete estrogen. So right around day 5, those estrogen levels are high enough for them to tell the uterus, hey, start building up that endometrium again. So the proliferative phase is the endometrium is repairing itself. That means the cells are dividing, it's starting to get thicker. Then day 14, up here in the ovarian cycle, we have ovulation. And once we have ovulation, a corpus luteum forms and it starts secreting progesterone. And that rise in progesterone triggers the secretory phase in the uterus. And this is where the endometrium is getting thicker and thicker. And it starts forming a whole bunch of secretory glands that are producing a whole bunch of secretions. And a lot of those secretions are nutrients that will support whatever is going to implant. That's a secretory phase. If up here in the ovarian cycle, if we have fertilization, the corpus luteum is going to stick around. And if the corpus luteum sticks around, that means that progesterone levels are going to stay high. And if progesterone levels stay high, that means FSH and LH levels will stay low, and we won't start a new ovarian cycle, and we'll just keep this old one essentially going. We don't start a new one. If fertilization has occurred and the corpus luteum is sticking around and progesterone levels are high, that means the endometrium is going to stay nice and thick and secreting lots of nutrients, which is what we want for that pregnancy. The corpus luteum will stick around until placenta forms. Once the placenta forms, it will then secrete the progesterone. So during that pregnancy, one key thing of a good pregnancy, progesterone levels have to stay high because it keeps the endometrium nice and thick, secreting lots of nutrients. If, however, no fertilization happens up here, then the corpus luteum is going to die off right around day 28, give or take a little. Corpus luteum will die off, and if the corpus luteum dies off, progesterone levels will drop. And if progesterone levels drop, then we're going to start a brand new uterine cycle, and that nice thick endometrium that we just formed is going to slough off. And then we start the whole thing all over again. So when you're learning these cycles, what I suggest that you do is draw out a little timeline, put the different dates on here. First, put the different cycles. So the ovarian phases. Ovarian cycle, you've got the follicular phase, the luteal phase. Say what's happening in the follicular phase. That's when your follicles are maturing. What happens in the luteal phase? That's when the corpus luteum forms. What happens on day 14? That's when ovulation happens. And then say what causes this to happen. Beginning of the ovarian cycle, the follicular phase is due to FSH levels from the anterior pituitary rising. Ovulation due to a surge in LH. Up here, you want to say, what are these follicles secreting? They're secreting estrogen. What's the corpus luteum secreting? Progesterone. Come down here to the uterine cycle, list the different phases. Say what's happening in menses. Endometrium sloughs off. Why does it slough off? It sloughs off because there's a drop in progesterone coming from the ovaries. Proliferative phase. What's happening? Endometrium repairs itself. Why? Estrogen levels are rising. Where's that estrogen coming from? The developing follicles up here. After ovulation, secretory phase starts down here. That's the endometrium getting thicker, secreting material because it's producing secretory glands. Why? Because progesterone levels rise. Where's progesterone coming from? Corpus luteum up here. So you're going to tie these two things together. Again, a successful pregnancy, you've got to have both of these cycles matching up. It's great if the uterus is prepared, but if you're not ovulating, then the uterus can be prepared, but you have no cell to get fertilized. Or you could be ovulating, the cell gets fertilized, but if the uterus is not thickening up the endometrium, you won't have implantation, and you may have fertilization, but you won't get implantation, you won't have successful pregnancy. So you need both to be happening in sync with one another. Real important.
So too short of a luteal phase. Sometimes that's called.
Luteal phases are almost never short because luteal phases are marked by the corpus luteum, and it has a set time that it can stick around. When you get variations, it's usually in the first part of this phase, but this is pretty much standard. From the time ovulation happens, that corpus luteum will stick around about 12 to 14 days and then die off if there's no fertilization. So this part really doesn't change. This part can change from person to person. That's pretty much standard right there. It's just because corpus luteums, they have a certain lifespan. Those cells, if there's hormones present, then if there's fertilization, there'll be hormones present that tell it to stick around. And if there aren't hormones present from a fertilization, then those cells have a limited lifespan and they will just die off after 12 or 14 days.
And if there is fertilization, does that secretory phase just keep extending
Yep,
until?
it just stays. And so the endometrium will reach a certain thickness and then just plateau out. Okay, so just a note about menarche and menopause. Menarche, by the definition, is the very first cycle. And this occurs around 11 to 12. Now, we are seeing females starting puberty earlier than we used to. But I just saw a report where it says even though females are starting kind of the pre-puberty phases earlier, the first actual cycle hasn't really changed that much. And the reason females are starting puberty earlier, two main reasons for that. There are more estrogens than ever in our water supply, and a lot of that's due to pharmaceutical drugs going into our water supply. So having estrogens in our water supply will trigger this cycle to start. Also, young girls are more overweight than they've ever been. And remember, adipose tissue releases hormones. And the hormones that are coming from the adipose tissue are basically telling the brain, oh, this body is ready to support a pregnancy. And then it triggers puberty earlier. Those are kind of the two main thoughts. Kind of on the flip side, if you have girls that are particularly athletes, you see this in gymnasts a lot. If you have girls that have a very low percentage of body fat, they can start puberty much later. They will not start their cycle much later. And it's, again, the brain kind of saying there's not enough energy reserves in this body, not enough adipose tissue to support a pregnancy. So we're just not even going to release these hormones, or the hormone levels will stay very low. So if FSH and LH levels stay low, then you won't trigger an ovarian cycle. And if you're not releasing enough estrogen and progesterone, then you won't have a menstrual cycle. And so you can see this, you can have a halting of your menstrual cycle anytime in adulthood. A lot of it has to do with certain developmental abnormalities can cause that to occur. A lot of stress can affect your hormone levels and keep you from having a cycle. Malnutrition, definitely. If females lose a lot of weight and their body or their fat percentage becomes very low, they can stop having a period. So lots of things can cause that to occur. Menopause, on the other hand, is when this cycle stops. And a lot of people think that menopause occurs because you run out of eggs or oocytes. That's not why it happens. It's hormonally driven. You can still have the oocytes there, and they'll just die off, but that's not what triggers menopause. Menopause is triggered because hormone levels start to vary, and then you stop having these cycles because estrogen levels will start to plummet, basically.
I've seen, or not seen, but heard of cases where a female can just continuously have, I guess, slough off.
Mm-hmm.
And what would cause that?
So, like spotting, basically? Okay, so let me back up. So, sometimes when females are on certain birth control, it can, if these hormone levels are fluctuating right around kind of the trigger point for the sloughing, that can cause it to just kind of continuously slough off. Usually what happens is you get a big drop in progesterone, and that causes it all to slough. If you're on certain hormones or you're having issues with your hormone levels, it can cause progesterone levels to drop a little bit, and that will cause sloughing, but they don't plummet. So then you keep some of that endometrium there, and if progesterone levels drop below a certain point, then you'll have sloughing that happens. That's real common. The other thing that you can see sometimes is people that are on certain kinds of birth control really won't have a period necessarily. And a lot of that has to do with, because when you're on birth control, you're taking estrogen and progesterone combinations depending on what the birth control is. So what the birth control is doing is it's keeping estrogen and progesterone levels just high enough that it keeps FSH and LH levels just low enough that you don't have follicles developing and you don't have this surge and trigger ovulation. And then because the levels are, just high enough to keep FSH and LH levels low, but not so high that you get a nice thickening of the endometrium, then there's really not much to slough off. So depending on the type of birth control that you're on and the particular combination of these hormones, you can see kind of varying degrees of that. And it's probably something along those lines.
I'm wondering if you've heard of anything, any relations between the consumption of soy and that triggering earlier puberty?
So I don't know a lot about it, but my understanding is that soy is a natural source of estrogen. And so anything where you're getting higher levels of estrogen than normal, let's say, that could trigger an early puberty to happen. Now, I haven't seen anything that says early puberty is necessarily bad, but I don't know, I haven't seen anything that says if you start an early puberty, then you will have an early menopause, and then that could be bad for certain health reasons. I've never seen that link happen. And they may just not know because, there's not that much data on it yet.
So health reasons like osteoporosis?
Yeah, exactly. Yeah, but I don't know that there's any correlation between that. So let's just kind of get through these other slides kind of quickly. The vagina, I don't have a lot to say about this. Obviously, it's going to be a passageway for birth, menstrual flow, and then the organ of copulation for females. We've already talked about the fact that there is a natural flora of bacteria that are in the vagina, and that's a good thing. They should be there. That bacteria are going to be supported by the mucus that's coming from the cervix. That mucus is rich in lipids and carbohydrates, and that allows the bacteria to make ATP they can use as a nutrient source. The metabolic activity of the bacteria, so the bacteria just doing their various chemical reactions, releases a lot of acidic components, which again is a good thing. Those acids are going to help restrict growth of other pathogens that shouldn't be there. And it also is going to help to inhibit the sperm motility, because sperm don't like an acidic environment. Now again, the sperm have adapted to that by having buffers in the semen. And then also around ovulation, we said that this mucus will get thinner. That will keep the bacteria from producing as much acid, and then the sperm won't be as affected. So there's lots of things that are going on to allow the sperm to be more successful around ovulation, and then outside of ovulation, make it harder for the sperm to survive in the female reproductive tract. And again, it's because the female body sees the sperm as being a foreign cell. It's a foreign invader, essentially, and so it's going to combat that. Now, I don't think I mentioned to you guys, but this is always a good thing to know, that foreplay actually decreases the acidic environment. So if you're trying to get pregnant, foreplay is actually very good because it will decrease this acidic environment and allow the sperm to be more, to survive that environment better. Now the problem is that you probably don't want lots of guys to know that if you're not trying to get pregnant. But it's always something you can just kind of, you know, it's good cocktail conversation. It's good to throw out there if you're trying to get pregnant and increase the amount of foreplay. Something to throw out there. You can say, my teacher told me that we have to do this because. So we've covered all this stuff already. In terms of the mammary glands, we're gonna. I'm not going to ask you anything from this slide. We're going to talk about milk production when we talk about development. So just axe this slide and we'll come back and talk more about that later. Now, in terms of hormones, we basically have covered what I want you guys to know about hormones. Let me just skip over here. These slides here are just looking at what's coming from the hypothalamus, what's coming from the anterior pituitary. These are the effects of estrogen. And we've mentioned this before. Estrogen is going to have many different target sites. It's going to stimulate bone. We talked about the effects of estrogen on osteoblasts. It's also going to help with muscle growth, not nearly like testosterone does, but it does play a role. Obviously, it's going to be involved in female sexual characteristics, central nervous system activity. It's going to maintain reproductive glands and organs, and it's going to obviously affect the uterus, the endometrium. Okay, so the key things, and again, we've talked about everything that's on these slides. It's just redundant. The key things when you're going to learn these cycles and learn the different hormones, I would say this is the slide that you want to be comfortable with. This slide right here is showing you the hormones that come from the anterior pituitary, the hormones that come from the ovaries. Over here, this is showing you the ovarian cycle, what's happening in the ovarian cycle, and then this is showing you what's happening to the endometrium. And so once you're done studying this material, you should be able to look at this slide and match these different phases up. You should be able to say, at the end of the follicular phase in the ovary, what's going on down in the uterus. And you should be really comfortable lining these up. Again, the key thing to remember is the anterior pituitary hormones are influencing the ovarian cycle. The hormones that